scalp. So in this we will be discussing the layers of the scalp, its blood supply, its nerve supply and surgical importance. So in the scalp is the term is derived from the first word of the different layers which are present in the scalp. So S represents the skin, C represents the connective tissue, and A represents epicranial aponeurosis. That is, A stands for aponeurosis, then L stands for loose irregular tissue, and P stands for pericranium. Then coming to scalp, it has layers of soft tissue that covers the cranial vault. So that is called scalp. And the scalp extends from external occipital protuberance in the back, then superior nuchal lines both on the back, then up to supraorbital margins. So the extension is from external occipital protuberance and superior nuchal lines in the back to supraorbital margins in the front. And the scalp consists of 5 layers: the connective tissue, epicranial aponeurosis, loose irregular tissue, pericranium. I repeat, the scalp consists of 5 layers, that is skin, connective tissue, epicranial aponeurosis, loose irregular tissue and pericranium. And the first 3 layers are bound together as a single unit. Then first we'll start with the skin and connective tissue. The skin is thick in the scalp and it has hairs and has numerous sebaceous glands. Then coming to connective tissue. The connective tissue is also called as superficial fascia. It is fibrous and fatty and it connects the skin to the deeper aponeurosis of the occipitofrontalis muscle. And this connective tissue provides passage for nerves and vessels. Blood vessels are also firmly embedded to the fibrous connective tissue, and this attachment prevents vasospasm of the vessels when they are cut, and that leads to profuse bleeding. Then we come to third layer, that is epicranial aponeurosis, and here it is thin and tendinous. It is actually the insertion of occipitofrontalis muscle. And coming to the attachments, one attachment is superior nuchal line to the superior temporal line. Laterally, the epicranial aponeurosis continues as temporal fascia. Anteriorly, a subaponeurotic space extends up to the upper eyelids. So attachments are superior nuchal line in the back. On the sides, it is superior temporal line. And laterally, the epicranial aponeurosis continues as temporal fascia. Anteriorly, a subaponeurotic space extends up to the upper eyelids. This space provides a potential space, that is aponeurotic space, that allows fluids and blood in case of injuries to pass from 4th layer up to the upper eyelids, causing a condition called as black eye. Then we go to study the muscle, that is occipitofrontalis muscle. This muscle has 2 occipital bellies and 2 frontal bellies. Coming to origin of occipital bellies is from superior nuchal lines. Then frontal bellies arise from the skin and superficial fascia of the upper eyelids. Coming to insertion, the occipital and frontal bellies insert into epicranial aponeurosis. And the nerve supply, occipital belly is innervated by posterior auricular branch of the facial nerve, and the frontal bellies are innervated by temporal branches of facial nerve. Coming to action, the frontal bellies raise eyebrows and form wrinkles of forehead. Together, they move the scalp over the vault. Then coming to loose irregular tissue. that is the fourth layer. So this layer connects epicrenal aponeurosis to the pericranium. And this layer allows the superficial 3 layers of the scalp to move over the pericranium, that is the 5th layer. And in this layer, emissary vein travel in this layer. They connect, these emissary veins connect the scalp veins, that is extracranial veins, with intracranial dural venous sinuses. Then we come to the 3rd layer or the 5th layer, that is periosteum, that is outermost cover over the skull bones, and along the suture lines. The pericranium is continuous with the endosteum of the inside as suture ligaments. Cephalohematoma is a condition that is due to accumulation of blood and is formed in the shape of respective skull bones. And in this we can see the nerve supply the scalp. So nerve, that is scalp is supplied by 10 nerves totally. 8 are sensory and 2 are motor. And you can see there are 5 nerves in front of the ear and 5 nerves behind the ear. And out of which 1 is motor in the front of ear and another even in the back also there is 1 motor nerve. So the motor nerve supplies the frontal bellies and occipital bellies. The occipital bellies are supplied by posterior auricular nerve and the frontal bellies are supplied by temporal branches of facial nerve. Coming from anterior to posterior in order, the first nerve is supratrochlear, then followed by supraorbital, then followed by zygomaticotemporal, then auriculotemporal. So these are the branches in front of the ear. Coming to the nerves behind the ear, starting just behind the ear, it is great auricular, followed by lesser occipital, followed by great occipital, and finally in the midline back, that is the 3rd occipital. So we have already discussed the nerves. So the nerve supply of the scalp is by supratrochlear, which is branch of ophthalmic division. And the second is supraorbital, again a branch of ophthalmic division, and it is lateral to supratrochlear. Then zygomaticotemporal is a branch of maxillary division. Then auriculotemporal is a branch of mandibular division. Then the 5th, that is just behind the ear, that is great auricular nerve, is a branch from cervical plexus, that is C2 and C3. Then we go to lesser occipital, is a branch from cervical plexus again, that is C2. Then we have great occipital nerve, it is a branch of posterior ramus of C2. And the 3rd occipital, that is from C3. And the motor are temporal branches are the facial nerve in the front and posterior auricular branch are the facial nerve in the back. Then we go to study the arterial supply of the scalp. So arterial supply of the scalp is by 5 arteries, that is front to back. First it is by supratrochlear, followed by supraorbital. Then we have just in front of ear, that is superficial temporal, and just behind the ear it is posterior auricular. And in the back we have occipital arteries. Then blood supply of the scalp, it is richly supplied and they are present in the connective tissue layer. They anastomose freely in the scalp. From midline anteriorly, the arteries are starting with supratrochlear artery, then supraorbital artery. Just in front of the ear, it is superficial temporal artery. Just behind the ear, it is posterior auricular artery. And in the back, it is by occipital artery. Then we go to lymphatic drainage. Lymphatic drainage, that is in front of the auricle, it is to parotid and cervical lymph nodes. And behind the ear, scalp is drained into occipital and posterior auricular lymph nodes. Coming to applied anatomy, the wounds of the scalp bleed profusely because the fibrous fascia in the connective tissue layer prevents vasoconstriction. Second, the wounds of the scalp superficial to aponeurosis gape much less than do the wounds that are cut through it. And the third one is during difficult labor, that is birth, bleeding may occur between the pericranium and the vault of the skull, resulting in collection of blood known as cephalohematoma. Then coming to the fourth one, there are emissary veins that connect extracranial vein with the dural venous sinuses. Infection can spread from scalp to the cranial cavity through the emissary veins. The loose layer of the areolar tissue is known as dangerous area of scalp, and scalp is one of the most common sites of sebaceous cysts. Then we go to study another competency, that is emissary veins with the role in the spread of infection from extracranial route to intracranial venous sinuses. Emissary veins connect veins outside the cranium with the intracranial venous sinuses. The important functions are they help in equalizing intracranial pressure and they act as safety valves during cerebral congestion. And these veins are valveless. Ophthalmic vein as emissary vein. It performs similar function as emissary veins by connecting exterior with the interior cranium. For example, angular vein anastomosis with ophthalmic vein and travels through the orbit. Then it travels the superior orbital fissure to reach the cavernous sinus. They carry infection. So the emissary veins, they serve as pathways by which infections are spread into the cranial cavity. That's why the fourth layer of the loose areolar tissue is referred to as dangerous area of scalp. Then applied anatomy. In surgery of mastoiditis, there can be cavernous sinus thrombosis. Then there is one dangerous area face is also cause of cavernous sinus thrombosis. And the area of dangerous area face includes the root of nose as the apex and the upper lip as the base. And the sides of the nose are included into this. So it is a triangular area starting with apex at the root of nose and base is the upper lip, and it includes even the lateral sides of nose. So that is called the dangerous area face. Thank you.